Good morning. First of all, I would like to thank the honor of this invitation. It is a pleasure to be here. And yesterday I learned so much that it's quite interesting to participate in this meeting. Okay. As a specialty of pain management has grown and developed, ethical challenges are emerging due to multiple factors, such as managed care and increasingly invasive intervention. If it's true that if medicine can delineate the physical and the biological entities as its domains of responsibility and leave the rest to the other professions, then medicine can insulate itself from the responsibility to acknowledge and respond to pain and suffering, then result from a patient experience of illness. And certainly we have an ethical dilemma. Thus, this communication aims to argue that bioethics have something important to offer on this quite challenging issue. From the theoretical to the practical, bioethical reflection and activities can illuminate the problem of unrelieved pain. We will organize our talk in 3 parts. In the first part, we will try to illustrate that pain management and its neglect is an ethical issue. The second will describe a possible ethical framework to shape the ethical issues of pain management. And third, uses this conceptual reformulation to suggest strategies of preventing the problem of unrelieved pain in terms of ethics. 2 facts about pain assessment and management are uncontroversial. The first is that healthcare professionals have an ethical obligation to relieve pain experienced by patients. The second is that this obligation has been largely neglected. Different studies shed some light to the problem. Over half of the post-operative pain goes unrelieved. Between 7 to 80% of nursing home residents are estimated to experience pain daily. Even when patients are dying, the numbers do not look any better. Half of all patients have moderate to severe pain. So, widespread are the stories of unrelieved pain at the end of life, that some believe that the public support for euthanasia or physician-assisted suicide is driven by the fear of dying in pain. Different barriers of effective pain management have been described. The first one, the failure of physicians to identify pain as a priority in patient care. This links to the prevalence of curative model over the paradigm of palliative model, so the dominance of the scientific approach over the humanistic approach. The second one, the failure of the physicians to set up a therapeutic alliance with the patient, thus jeopardizing the possibility of understanding the subjective language of pain. 3, insufficient knowledge among clinicians about pain assessment and management that has been discussed along this conference. The persistence of irrational beliefs and unsubstantiated fears associated with opioid prescription and consumption in pain relief. Failure of healthcare systems to hold clinicians accountable for pain relief. And resistance of patients and families members to the use of opioid, and last but not the least, cost constraints. How we think about pain influences how we respond to it. Our ability and willingness to detect it, report it, hear it, trust it, and treat it relies, in part, on what we understand pain to be and to mean. And how we think about pain is guided by those unspoken burial conscience, assumption, myths, and metaphors that shape our understanding of reality. Therefore, taking into consideration the specific case of pain management, in our opinion, the most relevant aspects are the ethics of care, with a focus on medical-patient relationship as a therapeutic alliance, the narrative-based ethics that takes into consideration the subjective dimension of the pain language, and the principialism that may enable us to structure the main ethical dimension of pain management. It is important, in our opinion, to underline that all relationships between the one that suffers and the physician must be an alliance. Therefore, in order to build this therapeutic alliance, cognitive skills, emotional preparation, and reflective capacity are critical components of the clinical experience. However, since the curative model in modern medical education and practice is still the reality, these kinds of skills are not easy to find. Pain challenges, by definitely strengthening the mind and body dualism characteristic of this curative model that persists in our Western culture. In fact, the curative model, grounded on the bias of dualisms of medicine, has been subject to critique as it appears to create an hostile environment for good care of gravely ill, painful, and dying patients. Often, the curative model of care is perceived as competing with the one on palliative care, as if these models of care would be completely separate and distinct realms. For example, while the curative model of care is analytical and rationalist, the palliative model is humanistic and personal. While the curative model privileges scientific objectives, the palliative model values the patient's subjective experience. And while curative model perceives death as an enemy, the palliative care model considers death as an inherent part of life and therefore embrace clinical and ethical demand of providing end-of-life care. Most recent perspectives, the WHO, for example, strengthening palliative care in 2014, emphasized the need of integration, with palliative care being considered simultaneously as an approach and specialist area of care provision. This approach recommends the integrations of the main principles and values and practice of palliative care in all forms of care. Serum tests, X-rays, and computer tomographies cannot communicate intensity, temporal quality, and distinct dimensions of pain. Only the patient can. And this requires the physician to observe, talk with, listen to, and trust the patient narration of pain, none of which physicians are thought to do. Physicians do not trust and hear the human voice. They, in effect, perceive the voice of patient as an unreliable narrator of bodily events, a voice which must be bypassed as quickly as possible so they can get around and behind it to the physician events themselves. Therefore, an ethics of care is a relation-based ethics based on emotional commitment and willingness to act on the behalf of persons with whom one has a significant relationship, that focus on empathic association rather than individual rights. It is relevant to pain management because it challenges impartiality and detachment, as well as the universal principles of ethics. Modern medical professionals have abstracted the problem of pain from its context, from its story. As we are trying to understand more seriously the problem of suffering, we are drawn back to narratives. This is because it is very difficult to determine whether and how much someone is suffering without being aware of the story that accompanies this experience. Therefore, we must call attention to other important ethical theories of interest for pain clinicians, the narrative-based ethics theory. Here, the story of the individual case becomes the core importance of paramount understanding. The subjectivity of pain makes communication through the therapeutic alliance essential to its amelioration. To have pain is to have certainty. To hear about it is to have doubts. The believability of pain is all the more confounded by its subjectivity. Pain cannot be generalized on the basis of objective factors that signal a particular therapeutic response. People experience pain quite differently, depending on factors as variable as their neurobiology, cultural upbringing, and current psychological and spiritual stage of being. There is a broadly based humanistic ethics which applies to the domain of medical care, which gives a patient a strong prima facie right to freedom from unnecessary pain, and which places upon medical professions different moral obligation. In this sense, responsibility and accountability at micro level, individual, patient and physician, at a meso level between interprofessional teams, healthcare and education organizations, and macro health systems, education systems and policies are therefore paramount. The most important way in which physicians demonstrate respect to their patients' autonomy is obtaining the patient's valid consent for any medical intervention. The consent process demonstrates respect for patient values and decision-making capacity. Eric Cassell explains, for the suffering person, autonomy is removed when purpose are directly by immediate needs of the sick body or by the compulsion to address what is perceived to be the source of suffering. Physicians have a duty to take positive steps to help others and not just to refrain from harmful acts. In fact, health professionals witness to unnecessary pain have an ethical and also the ontological responsibility toward those patients, even if they are not clinically responsible for them. It makes the further claim that since moderate to excruciating pain can be physical and psychological harmful, preventing or alleviating such pain is not merely a matter of doing good, beneficence, but also to preventing harm, non-maleficence. That is part of the Hippocratic Code. In addition to respecting autonomy, preventing harm, and promoting good for patients, physicians have an obligation to promote justice in the distribution of these goods. Distributive justice refers to fair, equitable, and appropriate distributions in society of a privilege, benefit, or service. Problem of distributive justice arise under condition of scarcity and competitions, where there is not enough to provide all that each needs or wants. And as an example, we may argue that nowadays financial constraints makes more difficult to provide necessary monitoring of patients due to overload or time pressure. Therefore, hindering the humanistic and relational approach needed to effectively assess, manage, and control pain. In fact, a lot of evidence shows that the access to pain control is currently grossly inadequate. Therefore, the barriers for good pain management are many and complex. Often cited impediments include the lack of education and training on the state-of-the-art of pain management, the lack of institutional mechanisms for routinizing the assessment and treatment of pain management, the lack of accountability for the undertreated pain, and federal and state statutes and regulations erected to the fight of the war of the drugs and addiction that negatively affects and legitimate use of controlled substance. So, there is a need of practical ethics. This, in my opinion, is a constructive approach to an ethics of pain medicine that is animated by a core philosophy of medicine as a specific focal on uniqueness of pain, the pain patients and the pain clinicians. The philosophy of pain includes, first, defines the nature of pain. Second, recognize the variability and subjective on expression of the pain patient. Third, acknowledge and explicates the vulnerabilities rendered by pain. Describe the inherent characteristics and asymmetries of the patient-clinician relationship and defines the ends of pain care. That these ends entail the provision of good care links the epistemic domains of pain medicine to its anthropological focus and ethically sound conduct. The proposed paradigm of integrative pain care supports the basic deontologic structure of the professions, allows for a more articulation of clinical and ethical responsibility within the scope of particular general specialty and subspecialty practice, and uploads the value of pain care as an interpersonal interaction that seeks to execute good acts and hence as specially defined by the needs of patients and parameters of the clinical relationship. The practice of medicine, and more broadly, the practice of healthcare, is fundamental and ethical enterprise. In fact, the alleviation of all forms of pain and suffering, both acute and chronic, is an ethical duty of societies and health professionals, and has been recognized worldwide as an ethical demand and human right. Anyone who has personal experience, severe, acute or chronic pain will grasp its ethical dimensions. However, the challenge to pain reformers lies on the other side of that experience, moving people not in pain to acknowledge and treat those who are in pain. Even though knowing does not necessarily translate into doing. Using moral argument to establish the good is often the first step in motivating behavioral change to hard hit. No doubt, this task has been made easier by having an audience largely motivated by benevolence. Physicians and other healthcare professionals generally want to do good, but on the matter of pain, much more than an ethical call to action is needed. Healthcare professionals must seek to provide biomedical, technical and scientific care in ways that allow equal appreciation of patient values, good goals and choice, and which convey respect for the patient as a person. As stated before, the applied ethics of pain medicine must be pragmatic and therefore cannot rely upon or be reduced to a single ethical principle or system. Therefore, the logic of principalism, and when we talk about principalism, we are not talking only in the United States principalism, but we are talking about also the declaration, the Barcelona Declaration, that includes other principles like vulnerability, integrity, and dignity, and is more related with European cultures and values, must be put together into two previous mentioned theories in order to provide a dimension of objectivity to subjectivity of pain. In our opinion, the dignity of all actors in pain management scene must rely in the just equilibrium between the physician responsibility to be more humanistic and to avoid separation between the curative and palliative model, patient vulnerabilities that push the physician for the development of skills to understand subjectivity under the pain language. So, in this way, the other principles, autonomy, beneficence, non-maleficence, integrity, vulnerability, and justice, must include this relationship between someone that is responsible and someone that is vulnerable. Thank you very much for your attention.